Hi everyone, my name is Nicole Benavides, and today's topic is preserved renal allograft function and PD-1 pathway inhibitor Nivolumab. Definition: Nivolumab is a drug that binds to the protein PD-1 to help immune cells kill cancer cells better, and it is used to treat many different types of cancer. This includes cancer that express the protein PD-L1 or that have certain mutations in genes involved the DNA repair. Normally, it helps to prevent these cells from attacking other cells in the body. By blocking PD-1, these drugs boost the immune system response against kidney cancer cells. This can often decrease the size or slow the growth of some tumors. Immunotherapy. Immunotherapy is the use of drugs to boost someone's immune system to effectively recognize and destroy cancer cells. Various types of immunotherapy can be used to treat kidney cancer. Sometimes kidney cancer cells use these checkpoints of T cells to avoid being attacked by the immune system. So these drugs target in proteins at checkpoints, helping to restore the immune response against cancer cells. Here's the video.
New, groundbreaking immunotherapy cancer treatment that stimulates the immune system to fight cancer. Opdivo is approved for the treatment of locally advanced or metastatic lung, melanoma, and kidney cancers, and is being studied for many other cancer types. Opdivo is the trade name. Its generic name is Nivolumab. Opdivo is made by Bristol Myers Squibb. Opdivo is a new type of cancer treatment called immunotherapy. Basically, it activates the immune system from being dormant. Our immune systems are dormant until there is a need to fight foreign bodies, like an infection. Because cancer hides from the immune system, it doesn't know it needs to go to work. Opdivo is an antibody that binds to the protein called PD-1 on T cells that live in our immune system. T cells are like a car ignition that gets the immune system off and running. This stimulates the immune system to find and kill cancer cells. Opdivo is given intravenously on one day every 2 to 3 weeks in cases of advanced or metastatic cancer, but not in early stages of cancer at this time. Opdivo is used for the treatment of lung, melanoma, and kidney cancers. In lung cancer, Opdivo is used in advanced or metastatic non-small cell lung cancer that has worsened after treatment with previous chemotherapy, or has worsened after treatment with previous targeted therapy. For melanoma skin cancer, Opdivo is used in advanced or metastatic melanoma. In kidney cancer, Opdivo is used in advanced or metastatic clear cell kidney cancer that has worsened after previous treatment. Opdivo helps people live longer without the cancer growing, and live longer overall than if they did not take Opdivo or took other cancer medicines instead. Some common side effects that I see in my patients taking Opdivo are feeling tired, pain in muscles, bones, and joints, loss of appetite, nausea, cough, constipation, shortness of breath, diarrhea, or rash.
Here's other video.
As a scientist, I specialize in cancer immunotherapy. My work, and that of my colleagues, is to figure out ways to stimulate the immune system to kill cancer. To understand this concept, let's talk a little more about our immune system and how it works. Taking a look inside our body, all of us are born with an immune system that acts like the security checkpoint at the airport. Our immune system is like a high-tech full-body scanner system that protects us from things that are harmful. In the immune immune system, T cells have receptors that scan cells to distinguish between normal cells and abnormal cells, like virus-infected cells. Once detected, abnormal cells are attacked and removed by T cells. T cells also identify these cells for future recognition. The same T cells also play an important role in protecting us from cancer. Cancer cells are normal cells that have mutated. The more mutations cancer cells have, the more easily they are detected. Until recently, we didn't understand why T cells were detecting these cancer cells but not destroying them. But on a closer look, we've made some revealing discoveries. We've learned that one of the ways that cancer cells get past the security system is with the help of a molecule called PD-1 that is found on the surface of cancer cells. PD-1 is almost like a disguise that allows cancer cells to remain undetected. PD-1 basically hacks the T-cell scanning system by jamming the signal to parts of the T-cell system called PD-1 and B7-1. Think of PD-1 as a sensor that's part of the T-cell scanning system, and B7-1 is like an alarm that issues an alert when something is wrong. When PD-1 hacks the system, it prevents it from doing what it's supposed to do. In other words, it may prevent T-cells from destroying cancer cells. Scientists have been working on fixing this problem and have designed molecules to target the PD-1 pathway. You can think of cancer immunotherapy as kind of like a software update for your immune system. Early studies suggest that by targeting the PD-1 pathway, T cells may be able to detect and destroy cancer cells. Let me show you in more detail. T cells
Application in medicine. The susceptibility of transplant recipients to advanced cancer, squamous cell carcinoma in particular, strongly supports the hypothesis that immune dysregulations and deficits in immune surveillance contribute to carcinogenesis. However, one case report described preserved renal allograft function with preventive steroids and continuous recurrent use of sirolimus with Nivolumab, which may provide a potential means to administer anti-PD-1 therapy while preserving a transplanting organ. Here is other video.
I think as a scientist, you always hope that something that you discover will make a difference, never really knowing whether that will be the case or not.
Immunology has really promised to cure cancer for 100 years, but you couldn't go into your doctor's office and get an immunotherapy. CTLA-4 opened the door, and now PD-1 has really kicked the door wide open. Well, we identified the PD-1 ligand pathway, which turns out to be the major way that cancer turns off the immune response.
Dr. Hangzhou actually first cloned the PD-1. And then Gordon Freeman and Arlene Sharp, they actually helping identify how PD-1 binds to PD-L1, which we cloned it. We independently work on receptor and ligand, but we don't know this tool is relevant. Okay. Then Gordon Freeman and Arlene Sharp actually linked them together.
Well, our collaboration all started with a molecule called B7.
Gordon would clone the molecule and it's like, let's see how important it is. If we eliminate it from the immune system, does anything change?
Identifying the receptor-ligand interaction is like seeing a lock and a key relationship. And what we learned is this identifies the drug target, and it lets us then make a drug that keeps the key from inserting in the lock.
And we now appreciate that the tumor microenvironment has many layers of immunosuppression, and this pathway is a key mediator of these inhibitory signals, and that if you release that brake, then those T cells can enter the tumor and kill it.
When I was a student, actually, we learned from textbook talking about immune system. It's unlikely going to cure large tumor, especially late stage metastatic cancers. Now it's not true anymore. I think the textbook need to be rewritten.
You know, I do a lot of teaching of medical students, and I give a lecture on tumor immunotherapy. Early on, it was all of this hypothetical, and then it was with great joy that I had to rip up my lecture notes and start over, because now there are actually concrete examples of success.
This is transformative. This is the best thing going. 10 years.
Here is other video.
So basically, we know now that there is a new drug approved for metastatic renal cell carcinoma, Nivolumab, this anti-PD-1. But the issue is that most of the times we don't have a real biomarker to predict response. So what we did, we selected 9 patients treated with anti-PD-1, and we collected the tissue before treatment. And what we do is we try to find neoantigens or mutational loads as predictor of response for this treatment. The main issue is the main concerns is that we have only 9 patients, so it's a very small sample to get a real conclusion. But initially, what we have seen is that probably neoantigens might have a role, though not the mutational load. Yeah, so what we found is that patients with the neoantigens the level of neoantigens might predict the response to nivolumab. However, there is only few patients, so we cannot get a very robust conclusion about that. What we also did in this small sample is we were looking at a specific cytolytic activity, and what we saw is that a specific patient with a complete response that was on treatment for more than 13 months on response, he had a high cytolytic activity compared to the rest of the patients. So I think now what we are doing currently is what we are trying to do a multi-institutional study, trying to gather more samples from different institutions, and the main objective of that study is to try to get a real conclusion that might be applied to the rest of the patients, like to get a real conclusion to be applied to our patients treated with nivolumab.
Pros and cons. Pros. It can help stimulate the immune response against cancer cells. PD-1 inhibitors can often decrease the size and slow the growth of some tumors. It is a great treatment for people with advanced stage of kidney cancer. PD-1 inhibitors provide a significant and durable anti-cancer benefit. Cons. Risk of allograft rejections, cardiac adverse reactions, pulmonary embolisms, alterations in laboratory values like electrolytes and white blood cells, dehydration during the treatment, and here is other video about this topic.
Inhibitor. And there's some exciting data now going back to immunotherapy, where renal cell carcinoma's roots really began, and with a much more targeted approach in terms of immunotherapy targeting PD-1 and PD-1 ligand. And Brian, do you want to walk us through a little bit of some of the data that we've seen so far with agents targeting this important pathway and what we can look for in the future?
Sure. So, the way I describe this to patients is that, we started with immunotherapy, we've moved to VEGF targeted agents, and now we're sort of going back to immunotherapy, what I like to call more sophisticated immunotherapy. So Nivolumab is a drug that blocks the PD-1 receptor. So it's generally in a class of drugs called checkpoint inhibitors. So checkpoint is sort of the negative regulation of the immune system, the brakes that your body normally puts on any immune response, including an anti-tumor immune response. And so much like ipilimumab, which blocks CTLA-4, Nivolumab blocks PD-1 and in essence removes that brake. So there have been a very large phase 1 trial that was published in New England Journal that included a relatively substantial subset of kidney cancer patients, initially reported at last year's ASCO, I believe being updated at this year's ASCO, showing that there was clear anti-tumor activity to this drug as a single agent, which is impressive in the sense that sometimes immunotherapy has struggled to have activity as a single agent. It was also in a reasonable percentage of patients who had some degree of tumor shrinkage or control. And that's been the other difficulty with immunotherapy, is that maybe 5 or 10% of people respond dramatically, but the other 90 to 95 are left out. So that data was presented last year, and that drug is being really broadly developed in kidney cancer. There's a registration trial, second line versus everolimus. There was a trial of different doses in the refractory setting. There was a biomarker trial because there's been some work about PD-L1 expression, which is on tumor cells predicting response. And there's also combination studies ongoing, including a combination with Ipilimumab. Those drugs are made by the same company, BMS. And just today at ASCO, some very exciting melanoma data presented that suggested very early and dramatic tumor shrinkage from that combination in melanoma, again, being studied in renal. So I personally think this will be, you know, the next wave of paradigm shifting therapy in kidney cancer, and very exciting.
Issue of blind in Ecuador. Chronic kidney disease are prevalent in Ecuador that are so prevalent in Ecuador that are in the 10 most common causes of mortality. Between 2007 and 2016, 2,401 transplants and organs and tissues have been performed. 933 of them were renal transplant and allografts. Conclusion. Immunotherapy can lead to acute allograft rejection in solid organ recipients. The treating nephrologists and oncologists should be aware of this complication, and patients with cancer should know about their therapeutic options in order to make the best treatment decision in line with their lifestyle and goal of care. In some cases, the benefit of tumor regression may outweigh the unavoidable complication of allograft loss, especially in the setting of advanced metastatic tumors. Here is my social media if you want to check it out. Thanks, everybody.